So good morning, good afternoon, or good evening, based on where you are joining us from today, and welcome to today's webinar. My name is Laura Galanos. I'm the Executive Manager of the World Stroke Academy, which is the educational platform of the World Stroke Organization that provides stroke education to professionals worldwide. Now, it is with great pleasure that we are hosting this educational activity on unlocking the power of neuroimaging in stroke care from fundamentals to cutting-edge applications. We have exceptional speakers who will be sharing their expertise on the topic. And a special thank you goes out to Siemens Healthineers for supporting this webinar with an unrestricted educational grant, but also to the over 700 of you who registered for today's event and who are looking forward to listening in to their presentations. As per usual, and before introducing today's chair, a quick look at some of our housekeeping rules. We welcome any questions you might have throughout the webinar, but we kindly ask you to use the Q&A box for those in your Zoom control panel. So not the comments, but the Q&A box. You can use the chat box to say hi and tell us where you're joining us from or leave any other comments. An invitation to participate in our poll, it's just one, so please make sure to participate when we launch it. A reminder that the webinar is being recorded and the link will be sent out to all of you via email shortly after the webinar, but it will also be uploaded on the World Stroke Academy site and our YouTube channel. And lastly, we invite you to fill in the evaluation survey at the end to share your feedback with us, but also in order to claim your certificate of attendance. Now, without further ado, let me introduce today's chair and also our moderator for the Q&A discussion at the end, Professor Simona Sacco, Professor of Neurology at the University of L'Aquila in Italy, and current president of the European Stroke Organization. Simona, the floor is all yours.
Thank you, Laura. Thanks for this nice introduction. Hello, everyone. It's really my pleasure and my honor to be the chair of this very interesting webinar. The topic, we all know that it's very important for us. It's very important for our clinical practice because neuroimaging is something that represents really the basis to provide the stroke care. And in recent years, we've witnessed a lot of advancement in this field. And so it's really a pleasure to have the opportunity to go deep into this topic and to have the possibility to discuss. We have excellent topics, we have excellent speakers, so let's start, and please keep your questions for the end. So we can start with the first topic, moving fast and direct to angio, the best neuroimaging approach. And it's my pleasure to introduce Professor Grégoire Boulouis from the University of Tours in France. Please, Greg, the floor is yours.
Many thanks, Professor Sacco. Many thanks also for the invitation to talk in this great webinar of the World Stroke Academy. So I'm Grégoire Boulouis. I'm Professor of Radiology and an interventional neuroradiologist in Tours, which is somewhere in the center of France. So I'll be talking today about moving fast and direct to angio with a question mark, as you see, the best neuroimaging approaches. So the learning objectives are as follow. I will go quickly through them. So it's basically what we'll be talking today is not the specifics of it, but the workflows. So how does neuroimaging helps facilitating workflows for in-hospital stroke assessment? We'll also be, of course, talking about direct-to-angio approaches and assess what's the rationale and the clinical impact, and also the evidence that we have in the literature. And then at the very end, examine the role of integrated care platform to facilitate these transition from traditional imaging to intervention or other managements. This is basically the three first points are the key kind of structural points of this talk, and the last one is basically what will drive this thing is strategic workflow redesign for the whole neuroimaging assessment of stroke. So the first question, and now you see the poll, is what's your training background, so that we can kind of know who and then who is there. There's a lot of people, and adapt. Yeah. So maybe we give you something like 20 seconds. I've seen many people saying hi at the beginning, so it's very international. But question, is it pluridisciplinary? I guess so as well. All right. So there's 50% clinical neurology, a little bit of diagnostic neuroideology, and I'm very sorry for all the others, which I forgot, so in the poll. So a very few neurointerventionists. Okay, great. So to start is the question, so we questioned ourselves with the role of neuroimaging in stroke. So it needs to be accessible, accurate, fast, of course. It needs also to be scalable. That means cost effective, so you need to be able to deploy it at large scales, and safe. So what we have in mind when we see the title of this talk is basically the patients that are eligible for mechanical thrombectomy, and that means moving fast, direct to angio at a comprehensive stroke center. And then in this type of paradigm, the other patient, those that don't have a large vessel occlusion that's eligible for mechanical thrombectomy, will then be scattered through the different care pathways. And this maybe is possibly could have been the last slide. Is at the end, what we really want is a neuroimaging that has the characteristics that we said, but that brings the patient, every patient, as fast as possible to the point of care that's relevant to this patient. So there are some patients that are eligible for mechanical thrombectomy, and we want them as quick as possible in the angio suite. But the others, and we will talk about that, maybe not. So I won't be talking about mobile stroke unit because this is Young Chai's topic that's coming up very next. So if we take back the real workflow, and this is derived from the Mayence Goyal paper in 2021 in the SVIN. Basically, the patient has symptoms, the ambulance arrives, there's a stroke alert, and that allows you to have people ready at the primary stroke center if it's a drip and ship paradigm, or at the comprehensive stroke center if you're in the mothership paradigm. Then the ambulance leaves, goes directly to the imaging, whatever it is. We'll see about that. And at this point, you can scatter the patients that don't have a large vessel occlusion, like stroke mimics, MEVO, DEVO, hemorrhage, to their adequate care pathways. You can also administer lytics if the patient is eligible, and for the patient that require mechanical thrombectomy, they will be secondary transferred to the angio suite. That's a bit different for the mothership pathway. It's a bit, of course, faster because you don't have these intermediary steps, and it's basically the same type of thinking. Immediate transfer to the imaging, so that you can initiate the treatments, which can be lytics, other treatments if the patient don't have an ischemic stroke, and of course mechanical thrombectomy for the patient that are eligible. And as you can see, there are many rate limiting retarder spots at different points of these care pathways. Every step delays the time to treatment initiation, which of course has huge consequences for those patients that are eligible for mechanical thrombectomy. We will see that, and I wanted this out of the way. One question that comes up very frequently is whether CT or MRI can be optimized. Which one is the optimized approach for not delaying treatment initiation? And I wanted this, of course, out of the way quickly. So a long story short, MRI is a reasonable alternative if you have immediate access and it's optimized, basically. This comes from a very recent work that's under review. And I will not talk about CT or MRI protocols, which I leave to Alejandro, coming up after Young Chai in this webinar. So back to the initial rate limiting retarded spots. And here I will be showing you extract from the great movie by the Montpellier team, the SLICE team, which is called Fast for Stroke. And I'm sure you've lived these rate limiting points. So the ED arrival. So the first responders are dropping the patient in the ED. That's the first retarded spot. I will go quickly because you've lived that. I'm pretty sure. Then you transfer the patient to CT, MRI, wherever you're doing your imaging, and then you need to take back the patient to point of care. It can be the angio suite, but sometimes in the workflow, the patients need to go back to the neuro department to be monitored, and then back to the angio suite, and we're losing time at every single point. And in this movie, again, this is the Montpellier team. The patient then installed into the angio suite. So you see, this is a lot of time that's lost at every point. And the most intuitive patch for that is of course bypassing all these spots and going directly from where the patient had the stroke to the angio suite. That's the direct-to-angio suite or DTA paradigm to initiate lytics, mechanical thrombectomy, and then rescatter the other patients to the adequate care pathways. There's just, in this paradigm, there is just one rate limiting spot, which is entering the kind of ecosystem where your angio suite is. And I've figured here a rectangle, which means most of the time angio suite is not in a very accessible environment. And this may be a very important rate limiting spot, for example, if your angio suite is in the operating room. So going a bit deeper, next question is, what do we mean by direct to angio? So it can be a flat panel CT. We mean, of course, direct to angio for the imaging. It can be flat panel CT. You can also do a flat panel CT with a CT angiography with a venous injections. You can do a flat panel CT plus an angio, means if you don't see hemorrhage, then you just go to the angio, so you don't lose time and you don't ingest too much contrast. And of course, and now you can also do flat panel CT perfusion in some rooms. This is with the Siemens system, you can do this. Single dia multi-phase is basically you're requiring, I'm going quick on this video, you're requiring 8 different phases, and what you get is this 8 3D series from which you can derive again perfusion from the contrast intensity. It's basically, it's not exactly a deconvolution, but it's what you're obtaining, and you can get perfusion maps. So you get this output, which I've put as theoretical. It's not plug and play in the current system. So if you acquire, you need to have some software that can process your acquisition. But anyway, it may be the most adequate setting to use these most advanced technology, but I just wanted to give you the understanding that there's many different specifics about what direct to angio suite means. And most of the time now it's a flat panel CT, and then you do a flat panel CT angiography using venous injection, so that you don't do groin punctures for patients that don't require it, and you don't make the treatment potentially harmful. So what data do we have for this paradigmatic approach? So the data, the only randomized data that we have come from the Barcelona team with the AngioCat trial that was published in 2021. And a long story short, again, because we don't have much time, is for patients with LVO, so it works very well, decreases time, also costs less for these patients. It's true also in most observational studies that we have. There are approximately 20 of them. So for patients with a large vessel occlusion that are eligible for MT, it works really well, the direct-to-angio suite. And there are two trials that I know of that are still ongoing. It's the direct-angio trial. The results are unpublished, and the We Trust group, which is a Philips initiative. And we will just kind of talk about direct-angio for 1 minute. So basically, what's the workflow designed as is a patient with that have a known onset NA stroke scale of 10, race score of more than 4, are randomized to either standard imaging approach or direct-to-angio suite. And that's just to make people realize that that's at the point where it becomes a bit complicated. So if there is no ICH, then we do angio. If there is an ICH, then we go to the MRI, then to the stroke units. If it's not a large vessel occlusion, it's MRI, then stroke unit again. Of course, if it's LVO, then and the patient's eligible, it's mechanical thrombectomy. And it's true also for the patient that are randomized to the MRI approach. So as you see, and there are many, of course, different possibilities, other possibilities. This is not as simple as it seems, in which all the patients that arrive in the angio suite do have a large vessel occlusion that's eligible for MT. I'm going quick to the end of this parenthesis. So the study was prematurely terminated based on the recommendation of the Data Safety Monitoring Board, and we don't have the data we just know that the study is not recruiting anymore, and the analyses were performed last year, and publication hopefully will be available soon. So at the end, when we think of the direct-to-angio suite, the problem is the non-eligible patients, the patients that are not eligible for mechanical thrombectomy that you can see here. And these patients may derive harm potentially from this direct-to-angio suite. And there is a great, very recent paper in stroke in which the authors have demonstrated that for patients with intracerebral hemorrhage that are sorted in the direct-to-angio suite paradigm, you lose time for initiation of treatment that these patients require. So antihypertensive and anticoagulation reversal treatments. And since now, and you may actually also be losing money, but that's less important. And since these treatments are now fundamental aspects of the very recent ESO guidelines on intracerebral hemorrhage, I mean, we're trying to understand that this workflow may actually not be beneficial for everyone. So next step in this direct-to-angio, what if your angio is not just, let's say, or so to say, a flat panel CT, but that you also have a CT or an MRI that you can use. And this is possible. You can acquire a hybrid angio suite, which is also very useful for other aspects of interventional radiology, not just neuroradiology. And there are very few data, but again, it works. It works very well for these patients that do have a large vessel occlusion. And as we kind of move a little bit away from the using my flat panel CT to triage the patients, we come to the kind of almost the conclusion that's I'm going to go very quick on this slide because at the end it has a lot of pros. Of course, it's super fast, and when you think of what goes against the use of a hybrid suite, the most important one is the high infrastructure demand. It's like you need a big room, you need a big environment to use these angio suites, and maybe that's kind of the eureka. Is maybe your rooms and the ecosystem we're working in now are not designed for adequate stroke workflow. And that's the very last part of this talk is we need to move from the what was true 10 years ago when thrombectomy was not standard of care, which to what will be true in 10 years from now. That means that you have acute stroke spaces or acute patient spaces where everything is designed to move quick from imaging, from clinical assessment to imaging to intervention. So it's the direct-to-angio or the hybrid suites. It is a powerful acceleration strategy, but sorry, it's not a path. It's not the blueprint. That's, I think my belief is that we should not just use this as a means for acceleration, because this is just a means to correct the fact that we don't have adequate spaces in our hospitals for the management of these patients. So again, angio suites are not designed for full diagnostic workup. We do imaging compromises. It's suboptimal and likely harmful for non-thrombectomy patients and poses a lot of logistical problems, resource consumptions in many places. And again, many places cannot just afford to have an angio suite that's just waiting for patients. So at the end, and to conclude, if we come back to this, what we really want is not just the angio suite, but the entire environment for stroke. And that's the conclusion. We want to move fast. Time is brain, that's for sure. One size doesn't fit all. And the future, and that's the final point, is likely at least integrated. So best care will be delivered through high quality imaging plus immediate intervention. And that can be delivered in architecturally so dedicated environment. That means at the end that we need to remind ourselves that thrombectomy is a very young treatment and most of our hospitals still are quite old. And we must take all opportunities when we move from an old to a new building to participate in the discussion so that we have optimized workflow for these patients. Thank you very much.
Thank you, Greg. Thanks for this excellent and provocative talk. I'm sure that you will get questions at the end. And now let's move to the next topic, and we can start the discussion on mobile stroke units. And we have here with us Professor Yongchai Nilanont from Bangkok, Thailand. Please, floor is yours.
Hello, can you hear me?
Yes.
Can you see my slide?
Yes, yes.
Thank you, Professor Sacco. Hi, everyone. Thank you for the World Stroke Academy for the invitation. Our topic today will be the role of neuroimaging in mobile stroke units. So this is our learning objective, to identify the gaps in pre-hospital stroke care, because almost all of the operating system in mobile stroke unit is dealing with pre-hospital stroke care. And I believe in the future direction, that will be a paradigm shift to the MSU, especially in the pre-hospital stroke treatment. Number two is the assess the types of neuroimaging in the MSU and identify the roles of neuroimaging in the MSU. I would like to start from this slide. This slide shows everything we need in terms of acute ischemic stroke treatment. And it's labeled everything except for the MSU as a standard treatment. On the top, IBTPA, IBTNK is an endovascular treatment, as you know, is all become standard treatment. Stroke unit admission, aspirin, and also the general medical management. These are accepted as the standard of care. However, the MSU, as you may know, is not become the standard of care yet, but I would like to point out that there are several opportunities in terms of the pre-hospital over here, which is not arrived the door yet. So it's the the onset of 0 second to the door of the hospital. What we can do here is that we can shortening everything. Triage LVO patients, IV TPA, IV TNK, blood pressure controls, both in ischemic and hemorrhagic stroke. We can introduce reverse coagulopathy, or even neuroprotection or temperature control, and etc. These are the statistics in our center more than 10 years back from 2005 and 2018. You can see the bar graph on the left, which represented by the green bar. That's the time we lost or represent the onset to door. It's accounted for about 60% of the onset to needle times. We can say that 2/3 of the time that we lost between onset to recanalization are lost during the onset to door. So, and it's been there since 2005 or since we collected the data. However, when you look at the right side, the door to needle time, we've been collecting the data and we see the improvement of the in-hospital process. You can appreciate the continuous reducing from door to needle time from 90 minutes to approximately 30 minutes, 5 years in a row. So right now, after the implementation of the MSU, we are able to reduce the door to needle time to 18 minutes. So that's promising. The other thing we lost opportunity is that only 1/3 of the acute ischemic stroke patients referred to our hospital for EVT. Only 1/3 actually have the procedure performed. So 2/3 is considered as the future transfer. What I label here is what we are focusing our talk today is from the onset, and we're going to scan the patient pre-hospital and we initiate treatment or anything that can be done pre-hospitally on the mobile unit, all, including the LVO identification by I'm gonna say next by the imaging modalities that we have until we send the patient. And during that process, we're going to triage the patient, which patient will have which are eligible for EVT, and we send the EVT facility hospital directly. Our hospital established the mobile stroke unit and first launched 7 years ago. Right now we are having eight cars which owned by our hospital, and we are building another 5 by the end of this year. So in total we're gonna have 13 cars serving most of the provincial hospital which are situated in rural area. So this is the MSU workflow, starting from the FAST protocol, face, arm weakness, and speech difficulties within 4.5 hours, call national emergency number 1669. 2 cars are operating together. The regular ambulance pick up the patients at the scene. The big guy on the MSU going to the rendezvous point, which are predetermined. And when the 2 cars met, the patient will be transferred from the first car, small car, to the big car, and patient was scanned and treated accordingly. And of course, under the telestroke medicine. So there will be neuro specialists, and mostly are stroke specialists who are on call and will be available and see the patients and can be interactive with the patients or doctors who are on board with the cars. And CT, CTA, including IV TPA or IV TNK and CTA to identify whether there is large vessel occlusion, and including the neuro intervention to identify patients who are eligible for EVT and treated accordingly at the second hospital. This is what we performed during the COVID era. So you can see patients presented with speech difficulties, mild weakness of the right arms. We examine the patients. There are 4 people on board, the nurse, MDs, and technology, scan radiology technician, and also the driver. They are working together, and you can see the scan quality. It's not that perfect, but this is the first scan that we have with the 8 slide, the very first scan with the neurologica. Patients were diagnosed and TPA was given very fast. So I will play with the imaging study again, which you will see the subsequent CT again. And this is also another patient who are scanned with the same model of the CT scanner. During that time, it was selectom, 8-slide selectom. And this is non-contrast scan. You can appreciate the hyperdense basilar sign, which will appear very. Now you can see the hyperdense basilar sign over here. This is a non-contrast scan. It was pretty obvious. And well, to make things short, we re-examined the patients and we gave TPA within 4 minutes after arrival at the scene. And then we perform another scan with the CTA. So this is a CTA. You can see discontinuation of the contrast, which are, you can see here, discontinuation of the contrast in the basilar arteries. So the patient was triaged accordingly to the EVT facilities hospital. And EVT was performed, patients get better and everything's go well. Patients go back to ranking of 0. So right now, we start with, we are working with many teams, which are engineering department mostly. And we have a privilege of working with most companies, including the Neurologica and Siemens Healthineers. So you can see different types of, different model of the MSU and different types of the scan located on the MSU. I would say up until recently, we only have the scan from Neurologica, which are Cetom 8 slides and Omnitom 16 slides. For the BodyTom is not, I would not recommend putting on the MSU. So we consider only 8 slide and 16 slide Omnitom. And we have facilities of doing the scan both CT non-contrast, CTA, multi-phase CTA, and CT perfusion study if requested. And I will show you how the example of the quality of the images is enough for making decision according to whether you're gonna give TPA, whether this was stroke mimics, whether this was endovascular candidates. And mostly, I would say more than 95%, we satisfy with this type of image when you are pre-hospital phase. So last year we have the privilege with working the Siemens Healthineers, building the another MSU, putting the new model of the scan. You can see this is the new model of the scan which are built by Siemens Healthineers. It's a 36 slide scan. And you can see this is the shade, self-shielding with the back and front lid curtain cover with camera inside, so you can see how the patient's going. And this is the quality of the scan. Right now we have almost 30 scans of the patients running, and this is, for example, intracerebral hemorrhage with subarachnoid hemorrhage on this scan. And this is the CTA of the display machine. So it's enough for identification of whether the patients are having LBO or we are going to do the EVT. And this is the intracerebral hemorrhage. We have cross section, we have coronal section, and we have sagittal section. Okay. This is again the encephalomyelitis exchange of the old cerebral infarct. So I would propose, and we are going to this type of model of paradigm shift in terms of acute stroke care in Thailand. So we are building the MSU protocol, incorporating with the National Emergency Services. So on the middle part is the service platform of the MSU, which we are putting on the cloud with the AI that we are testing the AI for pre-hospital screen, whether the patient's having the acute stroke, and the data going to be sent to the emergency department, and then the neurology will be registered on the cloud, and they were met on the cloud with the telemedicine. So it's like in the future you are calling the cab, the taxi, and someone clicking to accept the work. The same thing here. Patients were seen by MSU and call for help. So consulting neurologists who are on call will be putting on call, and they accept the call and they see the patient on the cloud. And then they give the consultation services, whether to give TPA or to send the patient back, or to give to have the CTA performed, and then decide whether they're gonna have the EVT facilities hospital to be sent to the EVT facilities hospital. So in conclusion, the implementation of the mobile stroke unit is promising in bridging the pre-hospital gaps in pre-hospital acute stroke care, and the most practical use of the neuroimaging facilities include non-contrast CT, CTA, and multi-phase CTA, and sometimes CTP. Non-contrast CT can be performed reliably in marine MSU, which if we have time, I can elaborate further that we just finished the testing of perform the non-contrast scan on the marine MSU, especially in the supratentorial location. Telestroke and MSU can be used as an effective tool in treating acute stroke care with IV thrombolysis and in triaging the EVT candidate. Takeaway message. When you leave the room, I would like you to take away two messages. Number one, non-contrast CT, CTA, and multi-phase CTA are mostly enough in terms of decision-making in treating acute stroke in the MSU pre-hospitally, and it has several advantages. MSU telestroke with current imaging modalities can be used as a triaging tool in treating acute ischemic stroke with IV thrombolysis and in selecting EVT candidate. Thank you very much.
Thank you. Thanks a lot for this excellent talk, and congratulations also for the level of care you are providing in your region and your countries. It's really impressive, and I'm rather sure that you will get questions about this model. So now let's move to the final talk of this webinar before opening the discussion. And it's my pleasure to introduce Dr. Alejandro Tomasello from the University Hospital Valdebron in Barcelona, Spain. The title of the talk is Neuroimaging Protocols for Selecting Patients for Mechanical Thrombectomy. Please.
Okay, hello. Thank you for the invitation. And are you seeing the full presentation?
Yes.
Okay. Thank you. I will talk about neuroimaging protocols, and the learning objective. It's the role of imaging in the stroke treatment, and also we will look back a bit to see the changes we have had based on now on how we use the image information. Okay, something that it's quite remarkable in the imaging. Of course, we will use the imaging to select patient. This is, of course, it's the main objective, but it's super important to understand these protocols we have to include in our pathway, and of course, we have to do as fast as possible. And these two other things, it's mandatory. Of course, we will select these protocols based on the current evidence, but also we have to pay attention on our particular situation. Until recently, these were the criteria, you know, plain CT, CTA, or also MRI. We treated patients with aspect 6 to 10 and more than 6 hours to 24. We follow or we use the DON and diffuse 3 criteria to include patients in this time frame. But you know, the evidence advanced, and now we have to change a little bit. Now we know that we can treat, we're allowed to treat a posterior fossa. We know the effect of the treatment in posterior fossa, even it's in the late windows. And also we know what happened with the large core strokes. You know, there is strong evidence, especially in aspect 3 and 5. It's super useful. Also in very, very low aspect, but less quality of evidence. We know if we treat patient, we will reduce the progression of the infection, even if the patient arrived with an infarct by 150 millimeters. It's quite impressive. And something that we have to highlight is we treat this kind of patient because we will improve the ranking 3 block, which is super important. We will move patients to very low or high ranking, and we will increase the patient in ranking number 3, which is super. The motivation that produced that for the interventionists and neurologists, I think it's quite high. Also, we know this effect in the low aspect happened in different rate of age and in different, if the patient receive or not lytics. And also we know this effect happened in, especially there are more evidence in aspect 3 to 5, but also we have some information about aspect 0 and 2. This is stable after 1 year, and you know, we have now the recommendation to treat patients with low aspect, at least with 3 to 5 within the 24 hours. But also we have less quality of information, less quality of evidence, but in extremely large core from 0 to 2, still we have a pretty good results and a positive effect. And for me, this is super important. This, how can I say, this text highlight the fact that the era of large core thrombectomy has turned up the concept of core infant. Everything is changing, and in our understanding, we need to reduce the complexity of the imaging in order to offer more and more faster treatment for our patient. How we manage this in my hospital? From patients from aspect 0 to 10, up to 6 hours, plain CT and CTA. In patients from 6 hours to 24 hours, of course, we will treat patients with aspect more than 3, but also we are starting to try to understand the effect in aspect 0 to 2 in this late window. Regarding the perfusion, of course, the perfusion will help us, but differently compared in the past. For example, we know if we perform perfusion, especially in low NIH, we will increase the rate of occlusion vessels. We ran this study in our hospital, and we know if we perform perfusion, we will increase in 1/3 of 31% of patients. We will increase the number of the patients that we find an occlusion, intracranial occlusion. And this is super important, especially in low NIH, okay? Also, we know the quality of evidence, of course, is less, but in very, very late windows, up to 10 days, we know there are some groups that still the thrombectomy works. And we know that, you know that the time relative probably, and also in this group of patients, probably in the future, we will have to run a study to order to understand how to select this patient. This is the way that we face our treatment for patients for aspect 0 to 10. We will perform plain CT, CTA, in also we perform perfusion, especially if I think help us low NIH, and in patients with very low aspect, try to understand the effect of what happened with the patient with, for example, aspect 0, aspect 1, what happened with the thrombectomy. But also we are moving the time window in order to try to understand what really happened in the very, very late window. This is how we move the patient. I will share pretty fast. Patient with high suspicion of blood pressure occlusion and confirmed blood pressure occlusion from other hospital, we move direct to angio, compensity, rule out patient with hemorrhage. In patients with low NIH, changes in the clinical symptom, extend window, or some doubts about the clinical symptom, we put also in the CT, in the angio suite, but we turn the table and we slide in the CT and we perform CT, CTA, and perfusion. In very low suspicious of stroke, we send to another CT close to our angio. The use of MRI in our center, it's complicated. We take a longer time, pretty longer time compared with the CT, but we use in pediatric patients for sure, and also in patients with coma or paraplegia, more than 3 hours. Sometimes we send also patients for MRI in order to rule out patients with the infarct where we think we will not help the patient. But also we use the imaging in order to speed up the thrombectomy. For example, we take the information from the CTA and we evaluate the tortuosity. And we receive an email, it's super fast, we receive an email, and you can see in the lower part, left-hand side, you will see this carotid catheterization on the left side seem feasible, probably of success 99%. We put a threshold, and in this case, we know in 99% of the cases, we will achieve the catheterization in less than 10 minutes. And this is the way when we are starting to manage the arterial approach. We use the CTA information to select patients sometimes, but also we can use to speed up our treatment. Same with the radiological biomarkers of ICAD lesions. We can take some radiological signs in order to know if the patient, to predict if the patient have or not an ICAD lesion to treat. And here, this is a starting project, it's an ongoing project, but the idea is to use AI in order to predefine the possibility to treat a patient with the ICAD, which will impact in our treatment. And this is quite important. Also, we are using now the same kind of AI in order to choose or to know or to predict if we are allowed to achieve a distal occlusion and what will happen if we perform or not the thrombectomy. We know the results of the distal trial, but we will continue in the selection of this kind of patient, and I think we can use imaging in order to improve the way that we manage the indication. Super fast to finish. The imaging role is changing a lot. In the past, after Mr. Clean, after Revascat, we used the imaging in order to reason for not treat the patient. To rule out patients because in that moment, the idea was to select patients. After dawn, probably we continue doing this selection, but in extended window. We use the criteria based on perfusion in order to select the patient from 6 hours to 24. But in the time frame between 0 to 6, in that moment we changed completely the approach. We stopped to use perfusion to rule out patient, and we started to use the imaging, trying to find reasons to treat the patient. And it's super important, and I think changed a lot the way that we use the imaging in the last year. And just to finish a little bit, also we can use the imaging to tailor our treatment. It's mandatory. I think in the future, this is the way that we'll also manage the imaging to speed up the process. The imaging really can help us if we have better quality information in order to move fast to the patient, but also to offer faster treatments, okay? And also we can use the imaging in order to improve the rate of vessel occlusion, especially in distal occlusion and low NIH. And also this is starting, but also we will use the imaging in order to to perform the selection of patients that different kind of neuroprotection will impact in the outcome of the patient. And also the stroke unit is already presented. We will use to speed up the process in the in-hospital pathway, but also outside the hospital, okay? And regarding a little bit the conclusion, imaging can be used both to select and to include patients. A clear understanding of its strengths and limitations has a profound impact on the stroke treatment process. And I think in the future, different study lines in imaging should focus and redefine this capability and hasten decision-making in the acute care. And that's it. Thank you.
Thank you. Thanks for another very interesting presentation. And I'm very glad to see that we have around 10 minutes left for the discussion. And we have several questions in the chat, and we are open to receive also other questions. So please go ahead if you have questions to ask to our speakers. Let's start with one of the questions that I found particularly interesting and useful. It's about the catchment, the ideal catchment area for a mobile stroke unit. So the question is, what's the area covered by a mobile stroke unit efficiently?
Yes, thank you. Thank you for the questions. This is very practical. So the more rural area, the more the less resources you have, the more efficient of the mobile stroke unit. Or in other words, if you use the mobile stroke unit in big cities, it's not worth it. Or if you use the mobile stroke unit in near many hospitals that surround that areas, it's not effective. It's not cost effective. I would say putting the mobile stroke unit in the area that's in need. For example, in the far area, in the border zone, which our hospital, we have 8 mobile MSU, which belong to our hospital. And to answer the questions that one of the questions asking the cloud system, whether the expensive of the cloud system are the issue, but we are using average. So the 8 cars use the same cloud, so the costs are average. So that makes the cost of the operation less expensive. So to answer your question is that the less resource you have, the more need of the MSU it will become. Thank you. Right now, it's a matter of cost effectiveness. Some questions asking me about the cost effectiveness. I would say in our analysis of the cost effectiveness based on about 2,000 patients, we are about $1,000 behind for the quality of care of double the chance of getting triple the chance of getting reperfusion therapy, triple the chance of getting reperfusion therapy when you compare with the standard or usual care, and double the chance of getting back to modified ranking of 0 to 1. And the door to needle time was 18 minutes. So that's what we found. So you pay between $800 to $1,000 more when compared to the usual care. So right now is the questions of the mass production. If we use it more and more, the cost will going down. And I believe we will reach that level soon. Thank you.
Thank you. Thanks for clarifying this very important aspect. I can see one question for Greg. What is the NIH score to decide to bring the patient to the angio suite to detect a large vessel occlusion?
Yeah, I don't know if there is a kind of a recommended threshold, but most kind of studies is like more than 10, and cortical signs is basically the race score above 4 is having more than 10, and cortical signs is kind of a nice indicator of likelihood of a large vessel occlusion.
Thank you. There's one other question. I think this can be addressed to Alejandro, which is superior in stroke care, using CT or using MRI?
I don't know, but what I know is if you the quantity of information, if you have a lot of information and you know how to use it, it's wonderful. But the problem, it's like the gravity. If you have a lot of information and you don't know how to use it, probably you will find the reason to rule out patients for the treatment. And for example, talking about direct-to-angio, something that we learn moving the patient direct to angio, it's the incredible positive effect in the patient with high suspicion of large vessel occlusion that we move direct to angio. We found an incredible positive effect. And on that moment, we thought maybe it's to the time reduction and makes sense. But really, if we pay attention, also some part of this effect was because in this moment, we skipped the CT and we avoid the open selection of the patient. The answer to the question is both are okay, but you have to use it in the right way. This is the point. And I think, in my understanding, we can, and in our setup, we can simplify everything in order to treat patients based on the evidence. And of course, there are some part where we try to push the limit with the studies. This is more or less our approach. But I am not concerned. But when you perform MRI, you really, it's important to understand how to use this information.
Yeah, thank you. Thank you. I really agree with you. One question for Greg from my side. Is there any information about the outcome of patients with the stroke mimic, so not a stroke, but a condition mimicking stroke who are directed to the angio suite instead of the normal conventional stroke care?
Yeah, we don't have solid data for these patients. We basically don't know. I mean, it's so diverse, and so not that I know of, there's no data. But so that was in the conclusive slide. So these patients cannot derive benefit from direct-to-angio. So the best scenario is just 0.
Yeah, but the question is that can they get harmed of this different triage, because they are managed in a very dedicated and specialized setting, and eventually there's the chance that they can miss some sort of care or diagnosis or treatment because it's simply overlooked.
I fully agree. My feeling is that since the IO is no benefit, most likely it's a little bit of harm, and in some situations a lot of harm.
Mm-hmm. Yeah. One other question from Yon Chai. I saw that your model, you have 2 different units, one mobile stroke unit and one conventional ambulance going to the patient. And of course, this is associated with high cost since you have 2 different vehicles. Do you think that it's possible in the future to move to a single unit to save some costs?
Yes, of course, this depends on the context of each country. And the problem with us is that the place the patient lives is not in the big road, and we have to get inside, and the mobile stroke unit is huge, is big, and we only have 4 people working in the mobile unit. So in our context, it's better to have another team to get the patient down. For example, in the tall buildings, they have to move the patient down to the ground floor and transfer the patient to the rendezvous point. But in certain areas or in different countries, in the context where the road is big and you have people more on board, and then you can do it. Yes, but the principle is the same. It's the pre-hospital gaps. We're trying to close the pre-hospital gaps.
Yeah, thank you. And one last question, probably that just came in the chat. It's about hemorrhagic complication. There's a concern that the CT in the mobile stroke unit is less sensitive, and so you can get an increased risk of hemorrhagic complication if you give a thrombolysis.
Yes, the hemorrhagic complications, as we know, is not happen instantly on the mobile unit. It usually happens 12, 24, 36 hours later. So it will happen in the ward. And based on our analysis of patients who come with the mobile unit, based on compared with the usual care, it's not significant difference. But if you're asking whether the small hemorrhage that we are going to miss, it meaning that it's not hemorrhagic complications according to the treatment, but probably miss small hemorrhage. That's possible, but it's not. In our data set of almost 3,000, is not there yet. But there is probably small possibilities, yes.
Okay, thank you. Thanks for this answer. We are now out of time. It's 3 o'clock, at least in Italy, and so we have to close. I really wanted to say a big thank you to our speakers. The topics that were selected by the World Stroke Academy were excellent, as was the content provided by our speakers. I think we are again in front of exciting times in stroke research and stroke care, because there's so much going on with new ways to treat our patients with improved technology. Thanks once again to everyone. Thanks to everyone who joined this webinar, and to the World Stroke Academy. Bye.
Thank you. Bye-bye.
Thank you very much.
Thank you.
Thank you.
So.
Ciao, ciao.